All right. Hi, guys. Good evening. Good evening. You all see me? Hear me? Hi. Good evening, guys. Guys, today we'll have a ultra short session. I'll just do one small topic. I've got to be somewhere in the hospital. So I got a call. So I'll have to run through it. But before that, we'll just try to finish a small topic. I don't want to, break the continuity. So on that context, we'll start with a topic which is called as GIST. This is basically your gastrointestinal stromal. So gastrointestinal, it is your gastrointestinal, it is your gastrointestinal tumor. When you talk about the GIST is considered to be the most common mesenchymal tumor of the GI. This happens to be the most common. This is considered to be as most common, the most common mesenchymal tumor of GIT. Right? Now, if they ask you where is it originating from, the origin is going to be from the interstitial, is the interstitial cells of Kajal. It is the interstitial cells of Kajal. Now, this interstitial cells of Kajal is voice is low. Beta, we are on the maximum voice that we at. Yeah, we are already at the maximum voice. Try to increase the volume of uh, your device. Now, when we talk about the interstitial cells of Kajal, where do you find these interstitial cells of Kajal? Now, imagine that this is the lumen of the GIT. This is the lumen of the GIT. You all know the innermost layer is going to be mucosa. Surrounding mucosa, there is going to be submucosa. Surrounding the submucosa, you have the inner circular muscles. Surrounding the inner circular muscles, you have the outer longitudinal. We have the outer longitudinal muscles, and surrounding all this together, have the, let's say, the cirrhosis based upon what loop of bowel you're talking about. Surrounding this, the outermost layer or the, just for the sake of understanding, I have just put across like this. Now, when I say the interstitial cells of Kajal, the interstitial cells of Kajal are usually present in the outer longitudinal muscles, which we have already discussed it before. वॉइस अभी भी लो आ रहा है, क्या दिक्कत? All right, guys, can you give me a feedback? How is it right now? The feedback, how is the right now? Can you give me feedback? How is the volume right now? Okay, voice is fine now. Great. Chalo. Now, as I told you, this is the interstitial cells of Kajal, and we all know the blood supply, the gut would actually come from the submucosa. So, this is the submucosal lesion. Now, imagine if there's a tumor that is going to arise from the interstitial cells of Kajal, which is right across here. You will notice that as it continues to enlarge, it will grow into the lumen. Now, you can ask, sir, ये जो ट्यूमर है वो ल्यूमेन के अंदर क्यों ग्रो कर रहा है? Why cannot it grow outside? Because the blood supply to the gut is coming from the submucosa, so it is going to draw its vascularity from the submucosal vessels. Now, obviously, tumor will always grow towards its vascularity. So, over a period of time, you can see as the tumor continues to enlarge, this enlargement will be towards the lumen. Now, this is going to tell me two important things. Number one, as it grows towards the lumen, it is now going to obliterate the lumen or make the lumen narrower. Second, you will notice that because it is going to draw its blood supply from its submucosal vessels, you will see that this is going to be extremely vascular. This lesion is going to be extremely vascular. So, GIST is considered to be a hypervascular tumor. Now, usually when it goes into the lumen gets narrowed down. As the lumen is getting narrowed, obviously it will cause obstruction symptoms. And obviously when the mucosa is going to erode, it will cause bleeding symptoms. Now, when you look at the stomach, right, if I say in the context of understanding the most common site, if I say the overall most common site for GIST, it is going to be stomach. Overall most common type of GIST, it is going to be stomach, right? Now, if stomach is the second most common, will be small intestine. If it is not there, then it is going to be your colorectum. If not, then it is going to be your esophagus, right? If not, then it is going to be your esophagus. If not, then it is going to be your esophagus, right? Now, why I'm telling you so specifically about it is when you look at the stomach, if this is the esophagus, this happens to be stomach, the lumen of the stomach is going to be quite wide. So here it will not present to you with obstructive symptoms, such a wide lumen. So what is the clinical presentation you will see in respect to stomach? When you go down across here, the clinical features with respect to GIST in stomach. Because it is going to erode the mucosa, this is going to present to you with upper GI. This is going to present as upper GI bleed. So in an upper GI bleed, patient is going to present to you with hematemesis. The patient will present to you with hematemesis. Along with hematemesis, there will be melena, and due to blood loss, it will be associated with anemia as now, in an advanced disease or larger lesions, it can present to you with obstructive features. But remember, we'll talk about when we talk about intestine. The intestinal just will present you with intestinal obstruction, not in the case of stomach. In general, when we talk about the most common route of spread, the most common route of spread, it is going to be hematogen. It is going to be your hematogenous, that is bloody, and the most common site for second. The most common site for secondaries, it is going to. Now, another interesting thing that you will see the gist. The gist is found to be associated with a triad which is called as the Carney's triad. There's a triad called as Carney's triad, which is considerably associated with gist. The components of Carney's triad. Number one, there's presence of multiple gist at multiple sites. Number two, it is associated with pulmonary chondroma. It is associated with pulmonary chondroma as well as extra-adrenal or para then extra para gangly. Right now, as the patient is presented to you with an upper GI bleed, in terms of investigation, I will do an upper GI endoscopy where I will see a sub, or I can say it is going to be the presence of a mass or a lesion to identify. Now, sorry, because it is extremely vascular, I would not like to do biopsy. Here, we'd go ahead with C abdomen. It is going to be the CCT of the abdomen. The tumor markers that we usually rely on going to be your CD34, CD114, and you have, sorry, CD117, CD117, and dog, right, dog one. These are the markers. These are the markers that you will be relying on. Investigation of choice is going to be C. The tumor markers are this to be considered. Now, usually we'd go with the wedge-shaped resection. So, in the initial management, when I say the management protocols, whether it is a resectable or a unresectable, whether it is resectable or unresectable. Usually, when we say it's unresectable, there is presence of metastasis. In a resectable gist, I will send it for wedge or the wedge resection. Now, based upon the wedge resection, I would await the histopathology report, because based upon that, I know it is a benign or a malignant, right? Is it going to be a benign or a malignant gist? Now, for that, I hope everybody knows we follow a classification. That is what we call it as the Fletcher's. Is what we call it as the Fletcher's classification. I will give you a simplified version of the Fletcher's classification. Now, in the Fletcher's classification, I'll be considering the size and the number of mitosis. This mitosis get 50 high power feet. Okay, based upon that, you will have the report. Size less than 2 centimeters, mitosis less than 5. This is actually benign lesion. Size between 2 to 5 centimeters, but mitosis still less than 5. Then we say it is probably benign. Going to be probably benign. Now, size less than 2 centimeters but more than 5 mitosis, it is considered to be low malignant. It is going to be low malignant. If it is between 2 to 10 centimeters in size, it is 2 to 10 centimeters in size but mitosis less than 5, or else we'll make it this way. If it is between 5 to 10 centimeters in size with mitosis less than 5, then it is moderately malignant. But if size greater than 5 centimeters, mitosis more than 5, then it is highly, then it is highly yeah. This is the Fletcher's classification to tell you whether it is going to be benign or malignant. Now, for unresectable gist, for unresectable, will be using imatinib. The drug of choice for an unresectable gist, drug of choice. If there is resistance to imatinib, then the drug of choice here. So for the imatinib resistant gist, for an imatinib resistant gist, it is going to. So this is how you're going to manage your gastrointestinal stromal. Right? This was a small component that I wanted to do today. We'll resume back tomorrow with carcinoma stomach. That's it for today. So we quickly revise the entire component of GIST. Remember, from where does it usually arise from? It is hypervascular. It is going to present to you with upper GI bleeds. Carney's triad in GIST is important. Fletcher's classification is just important, which tells you whether it is benign, borderline, or malignant. And if it is an unresectable GIST, what is supposed, right? Thank you so much for joining. We'll resume back tomorrow. Until then, good night. Bye bye.